Put it on there. Thank you. Okay. Good afternoon, everybody. Whilst we're getting ready, I'd just like to remind you of the app. You've all downloaded the app. Okay? So the app is very important for you to be able to pose your question to the presenters. So once you've got your app loaded, you open the app, you tap the agenda icon, and you navigate to the session for this afternoon. Okay, you scroll and tap on the session, and you're able to type in your question that you have for the speaker, okay, or for the panel. So what we'll do now, without further ado, we'll start the session, so just that you're aware of how to use the app, okay? So the first speaker for this afternoon, so bearing in mind that this session, in a sense, continues with the theme of the conference and leads on from the keynote address this morning. Our first speaker is Dr. Kip Baggett, who serves as chief of the US CDC's Workforce and Institute Development Branch, which includes the agency's support for field epi training programs and National Public Health Institute development. From 2014 to 2016, he served as the Field Epidemiology Training Program Resident Advisor in Zambia, where he helped the Ministry of Health to launch this new program. Complementing his FETP work, he also supported the development of Zambia's National Public Health Institute. Before moving to Zambia in 2014, Dr. Baggett served as the director of CDC's Global Disease Detection Regional Center in Thailand and initiated engagement on the global health security agenda. A captain in the Commissioned Corps of the United States Public Health Service, Dr. Baggett completed his medical degree at the University of North Carolina and pediatrics training at Johns Hopkins Children's Hospital in Baltimore. He is board certified in pediatrics and general preventive medicine. He received an MPH in epidemiology from the University of Washington in Seattle and completed CDC's preventive medicine residency. Dr. Baggett, would you like to have a seat on stage? Or would you like to come up for your presentation, and then I will introduce the second speaker before his presentation.
Good afternoon, everybody. I hope everyone enjoyed lunch. I can see what this morning's presenters were talking about. It's very difficult to keep your eyes open up here. So it's a pleasure for me today to be able to lead off this session on the Global Field Epidemiology Roadmap. You heard a lot this morning from Dr. Martin, Dr. Morgan, and Dr. Ryan, a nice lead-in to that and how this fits into our into the FETP Enterprise. So my job in the next 10 minutes is to set the stage by giving a brief history of FETP and demonstrating how over the years the growth of FETP has also led to increased complexity of FETP, and I want to really use that to explain why we entered into this effort to develop the Global Field Epidemiology Roadmap and turn it over to the next speaker. So to get started, let's see, I can do the slides. So in 1951, CDC established the Epidemic Intelligence Service. People are familiar with this 2-year program in applied epidemiology training and service to address the shortage of field epidemiologists in the US. And then just a couple of decades later, Canada started its program, and soon thereafter, several other countries began to develop their own FETPs modeled after EIS. In 1980, Thailand, in collaboration with CDC and WHO, established its FETP. And this was a really important event for a couple of reasons. One, because it was the first FETP outside of North America, but also it was really the beginning of the FETP experiment in a way. This is where also we established a model of support that we've stuck with for quite a long time in terms of CDC's collaboration with countries on FETP development. CDC had a resident advisor assigned to Thailand, so a technical advisor based in Bangkok to work with the Ministry of Public Health to establish FETP. By 1990, the FETP initiative was well underway, and the progress of FETP to this point is summarized in this publication by Stanley Music et al. And in this publication, Music defines the long-term goal of FETP to create strong, self-sustaining indigenous training programs in applied epidemiology, which I think is something that resonates with all of us today. And he goes on to say that this goal can be achieved through institutionalization. And in the same paper, he takes the time to outline what he thinks are key factors for achieving institutionalization, things like leadership by a national director, organizational home and MOH, career paths for graduates, something we heard a lot about this morning, a lot of questions about that. And my point in showing this here is to show that these priorities that were identified at an early stage of the FETP experiment or the FETP initiative are still very true today. And I think these priorities also represent some of the most difficult challenges we've faced with FETP as FETP has grown as a larger initiative globally. This graph is from Music's paper, and if Eric Pevsner's in the room, somebody cover his eyes so he doesn't have a heart attack with these graphics. But this is, I said, early on in FETP days. So at this point, there are 7 programs described in this paper, and he's showing here the summary of the number of graduates by year. You can see a total of 193 graduates at this point. And I think for all of these programs, mostly done in collaboration with CDC, WHO, and USAID, there was a similar model of support for what I described for the Thailand program, where there was often a technical advisor or resident advisor from CDC living in the country working closely with Ministry of Health. There was a small team at CDC providing technical assistance. So it was a relatively straightforward model of support for these 7 programs as they were getting going. The programs described in Music's paper were all 2-year programs, which is the model directly after EIS. But over time, as I think everyone in the room is aware, we have gradually implemented and really scaled up a more tiered model of training to address public health workforce needs at different levels of the public health system. And I think this has been a really important innovation and a welcome advance, but it has also added to the complexity of managing that larger FETP initiative and thinking about those long-term priorities and goals. And so recall in 1990 in the paper from Music, there were 7 programs described. And in this slide here, in this graphic, we see the growth in the number of countries that are participating in FETPs since 1975. You see the tremendous growth over that time, and you can imagine parallel with this growth is increased complexity in the number of partners, the funding, and managing the priorities for the programs. There were 193 graduates in 1990 described, and here, as of this year, in the advanced 2-year program, there are over 4,300 graduates, over 1,400 graduates from intermediate FETP, and over 11,000 from frontline. So I think that really demonstrates the tremendous changes, the tremendous growth and success that have taken place since this experiment started in the early 1980s. A lot of the data that I show are really from programs that CDC has a direct relationship, and so I want to acknowledge that that information is an underestimate in a lot of ways because there are many programs out there that started without CDC support or have no longer need CDC support. And this is a map to try to give you a fuller view from a different perspective of the growth of FETPs over time. And this is a map showing the TEPHINET membership globally, which I think also demonstrates that tremendous growth. In the early years of FETP, as I've described, most of the support was largely coming from CDC, USAID, and WHO were also involved in the early days, mostly through provision of technical assistance through a resident advisor or from Atlanta. Over time, CDC and the US government has increased its contributions to actual program development, which I think has been important for lower and middle income countries along the way. And what I'm trying to show here with this slide is that as the CDC and US government funding has continued, the complex nature of the sources of those funds has increased greatly. There are many other sources of funds. There are many other funders in this, which brings many other partners, which is a very, very welcome thing, and I think demonstrates the success and interest in FETP, but also brings a layer of complexity. With the tremendous growth in programs and graduates, funders, and partners, this has really led to a need for networks that can advance FETP goals at a regional level and a global level. And I think all of these groups are represented here today, and we know the importance of these regional and global networks, including TEPHINET. In the early days of these networks, they were largely implementing partners really focused on implementation. So having funds to implement program. Increasingly, over the past decade, the networks have become really vital partners in other areas like technical assistance, strategic thinking, alumni networking, and deploying alumni for public health emergencies. So the partner network has grown, and with it, commensurate with the complexity of the FETP enterprise. Other global public health initiatives have also underscored the importance of field epidemiology capacity and FETPs. They have also increased the demand for FETPs. This example here, the International Health Regulations revised in 2005, underscore the importance of FETPs and really call out the need for a strong public health workforce in surveillance and response. The IHR monitoring and evaluation framework and the Global Health Security Agenda really codify this need for FETP by including it directly in the indicators. And Dr. Morgan mentioned it this morning, the inclusion of having FETP as one of the indicators in the Joint External Evaluation and setting specific targets for field epidemiologists. So in closing this first presentation, I want to return to the paper from Stanley Musick and the priorities that he set out. From the early days of the FETP experiment in 1980 until today, we've seen tremendous growth, tremendous success, and I would say tremendous impact from FETP. And we also can revisit these priorities spelled out by Musick and see that they are as true today as they were in 1990. And these priorities also represent persistent challenges that we've been working through for really since 1990 to try to find solutions to these difficult challenges to really achieve the full success of FETP and the full impact of FETP. And so that was the conversation over beers at the Safety Net meeting in Siem Reap in 2016. That's Anchor beer on the table for those who can't see it. And Martin Kirk, Patrick O'Carroll, Dionisio, and I think there are a couple of others there as well, were talking about this and talking about these challenges. Patrick was relatively new to the conversation about FETP, and so we were brainstorming about ways forward, and I think it was Patrick's idea to propose a meeting to really bring together people to tackle these challenges and bring more attention and energy to it. And this is where I'm going to pass the baton to him to let him tell the next phase of the story. Thank you.
have a seat at the bottom. Yeah. I think the bottom will be easier. Thank you, Kip, for the history and background of the FETP Enterprise. I'd now like to call upon Dr. Patrick O'Carroll, who will be giving us the background and the outputs of the Bellagio and Geneva meetings. Dr. O'Carroll oversees the Health System Strengthening Program of the Task Force for Global Health, including the Public Health Informatics Institute, TEPHINET, the African Health Workforce Project, and the MedSurplus Alliance. Prior to joining the task force, Dr. O'Carroll served for 31 years in various positions at CDC and HHS, including a term as Deputy Assistant Secretary for Health, for Science and Medicine, and Senior Advisor to the Acting Assistant Secretary for Health. Dr. O'Carroll, please come up on stage.
That's perfect. So let me begin by sort of reminding you all where we are in this process. This is a process whereby we, that is all of us in the FETP community, decide together on a collectively designed roadmap for where we're going from here. And if you say, well, how is that possible? We weren't involved in these meetings. Well, everyone couldn't be involved in these meetings, but we gave it a start. We gave it our best try. We think it's pretty good, but this is truly your opportunity to reflect on this and tell us what you think and ask questions and encourage us to think further about it and things like that. So that's why we have the app that you heard about. If any of you came late, you can navigate via the agenda to this session and tap on it. And you can then put in questions or comments or concerns or congratulations, whatever you feel like saying. We really want to hear from you. This isn't your last time to tell us this. There'll be other times. But this is truly meant to be our collective path forward and not something anyone has inflicted on you. So keep that in mind. And if you want to practice, you could comment on whether I look cool walking around with this cool microphone. And that would give you a chance to practice using the app. Okay, so let's get started. So as you heard from Kip, there's been enormous growth in the FETP initiative since 1975. And it's worth pausing there and just saying, this is an amazing success story. It really is. I mean, this is practically 40 years since 1980 in Thailand of the growth of FETPs, 4 decades of steady investment, steady growth, steady devotion by people all over the world to developing new programs, growing them, graduating FETP residents and so forth. Just a phenomenal success story. And I'm really proud of CDC and the ECDC and all of the program directors and everybody who's worked on this. It's just been phenomenal. Having said that, there are challenges, as Kip indicated, with the growth. Challenges of quality varying across programs, of slowness of institutionalization, of career path issues, as you heard brought up several times this morning. And there's also new techniques and new opportunities to use new technologies and new kinds of EPI, frankly, new ways to share and transmit data, all of which are suggestions that we may want to think about updating our curricula and things like that. So lots go on when you think about all the things that we're asked to do. And the final one listed is very important and frankly understandable by a lot of people who aren't in FETP, the kind of people who might want to fund us, which is that we are in fact a workforce that can respond not only to our own outbreaks in our own countries, but through mutual aid with other countries as well. And that's a very powerful thing that we can do. So as you heard, this, like all great ideas, they seem to originate by a bunch of people sitting around a table, frequently with beer, not necessarily with beer, but in this case with beer. And we kind of brainstormed around this idea, and it's amazing how far it's come through the energies of lots of people that I'll list for you in a few minutes. But it was just about a year and a half ago, in June 2018, that we got together in Bellagio. How many of you know about Bellagio, Italy? Have you heard of the Bellagio Center? Rockefeller has this amazing center, and if you're fortunate enough to get a grant from them, you can have a meeting there. And this is a view of it. And our CEO at the task force likes to say, if you can get a Bellagio meeting funded, you should, because no matter how important or busy a leader is around the world, they find it really hard to say no to an invitation to attend a meeting in Bellagio, because it's really a lovely place to go. But the idea was, let's get together and develop a roadmap for improving the way we're doing business and accelerating our progress. That was its ostensible purpose. This is an important slide. I hope you can all read it. These are the people who came. We have 19 bedrooms at Bellagio. You can only have 19 people. It's full stop. You can't have 20. 19's the max. So we really had to think who those people would be. And you'll see listed here several people who were in this room, several people who weren't able to be in this room, but all of these people were leaders. This is another way to look at this group of folks, and that's by agency affiliation. So you see we had a good representation from FETP program directors. We had good representation from our regional partners, very important development over the last few decades. The growth of regional partners like SafetyNet, AFINet, EMPHINet, who are close to the countries they serve, speak the same languages, understand the cultures and so forth. Terrific partners in helping to support FETPs. Our own Dr. Dionisio Herrera was at this meeting, and frankly on the planning committee along with Kip and Martin Kirk from Australia, and others from CDC, and others that you see there, including Dr. Copeland, who opened the conference, by the way, was there representing IANPHI. And we have Dr. Natalie Mayet here with us today, who's going to join us in the panel in a few minutes. So that's who was there, and the one person I hadn't mentioned was Oliver Morgan, who was supposed to be there for WHO, but unfortunately, because he's in the emergency program, he was called away to DRC, as you can imagine, to deal with the Ebola outbreak and was unable to attend, and that was really unfortunate. So we went on, though, with our meeting in Bellagio, and basically 3 things came out of this meeting. There were 3 products, and it's worth remembering that because the temptation is to focus on the third group, which is the 7 recommendations. And we're going to get to that for sure, and that's what we're going to talk a lot about. But the first 2 pieces there I want to talk about as well, and that is that this group got together. These are people who've been in this field for a long time, and we started by saying, well, let's go back to basics. What is it we're trying to accomplish? And so we crafted a vision that I think will resonate with all of you. It's not anything you haven't been doing, but it puts words to it so that we can communicate with everybody. We also defined a new conceptual framing that a lot of you have been hearing about. You may have been wondering what we mean by this or where this came from. But this idea of a global FETP enterprise came from this meeting. So, still working? See, it's not cool when I walk around with this microphone, so you can comment on that. And that new conceptual framing is this idea that we have something we're calling the FETP Enterprise. And I'll explain what that means in a moment. And then I'll go through the actionable recommendations. So the vision. Basically, this is the vision we came up with. Okay, that'd be great. You want to turn off the other? Can you hear me okay with this? Great. The vision is that every country in the world, when we're done, when this project is finished, when the idea of FETPs has been instituted as broadly as it can be, every country in the world will have the applied epidemiology capacity needed to protect and promote the health of its own people and to collaborate with countries nearby or elsewhere to help promote global health security. Notice that it doesn't say every country in the world will have an FETP program. It's not a bad idea, but the focus is on building capacity. And of course, the FETP programs are our primary means of building that capacity. There are, of course, regional FETPs that serve multiple countries. And there are probably other things we can do in addition to FETPs that can foster EPI capacity, like policy development at the ministry level, things like that. So the focus has been on building this capacity, and FETP is the primary means for doing so. That's the vision. This idea of the framing being different is as follows. The truth is, we are really engaged in a really complex global undertaking with lots of different partners. So what you heard the history, we thought it was important for Kip to share the history. What started as a single, granted program in Thailand and then a second program and a third, you could originally describe as there's a CDC grant program that helps countries stand up FETPs. It is much more than that now. We have many, many people investing in this program, starting with the countries themselves who invest in this program and the people who put their life's blood into it, who direct the FETPs and recruit students and train them and mentor them and so forth, and all of what they bring to it. Plus other funders. CDC is still the primary funder, no question, but ECDC puts in a great deal of funds as well to support the EPIET and MedEPIET programs, and foundations put in money, WHO has put in funds and time and energy and so forth. So it isn't just, not to minimize it, but it isn't only a CDC grant program. It's truly a multi-partner initiative. And we call this initiative the FETP Enterprise. And by the way, the enterprise includes things like this conference. This conference is not part of an FETP program, but it's central to the success of all FETP programs. And the accreditation process, we had a wonderful accreditation meeting that preceded this gathering that was a success right here in Atlanta. And that accreditation process is part of the enterprise. There are system-level things like that that are bigger than any individual programs. So this is what we mean by the enterprise, the totality of all the leaders, the funders, the implementing partners like TEPHINET and SafetyNet, IANPHI and TEPHINET, the government agencies, and all the other stakeholders and funders and suppliers who engage in this global effort, along with all of the standards and technologies and agreements that have been developed over time that we agree constitute the rules of the game for FETP. And we thought that was important because if this is indeed a multi-partner partnership, the question is who's running it, who's driving the train, who's making sure we solve these things. And that's why I thought it was very good to go over Stan Music's list as Kip did, because the problems that we were talking about that we're going to address through these recommendations have been around for a long time. And so if we think of ourselves as all owning this, then we collectively have to build the mechanisms to drive progress. And that's what a lot of this is about. All right, so here's the 7 recommendations. I'm going to go through them quickly now because in a moment I'm going to take you to the Geneva meeting where we dive deep into each one of these. So the first 2, and I'll pause on the first one in particular, you've heard a lot about this morning, is someone has to drive this train. Someone has to drive progress and make sure these problems are solved, to make sure the career path issue is addressed and not just talked about, for example, to make sure we find ways to accelerate institutionalization, to find ways to systematically fund programs in a sustainable way and so forth. We've got to drive progress to solution. And that's where this idea of a strategic, very high-level strategic leadership group came from. We'll talk some more about that in a minute. Second piece comes with this idea that things are changing. There are new challenges. There are new technologies. There are new techniques. And someone has to be monitoring what's going on, and there has to be a process for systematically updating our curricula and updating our processes and maybe finding ways to improve this conference, for example, and finding ways to expand accreditation into new areas and so forth. So there has to be somebody monitoring that and taking action to make needed changes. 2 more. It came out at Bellagio that it's very important for every country to be able to set its workforce targets, and now at the 3 levels that Kip described, so they know how many they're building for it. And you don't just say, well, we need an FETP program, and if a minister said, well, how many field epidemiologists do we need? Each country should be able to answer that question, and it should be not some worldwide standard, but rather what makes sense for that country. The 4th recommendation had to do with accelerating institutionalization. For this to grow, it has to become part of a public health authority's way of doing business. That involves policy, it involves leadership, it involves programmatic support as well as financing. Number 5, we need to be able to deploy specially trained FETP fellows and alumni to cross-border responses. Now, I say specially trained, I mean above and beyond what would normally be FETP training, or let's say traditionally FETP training, so that people understand how to work in incident command and how to work in humanitarian settings and how to fold into multi-partner responses and so forth. That's probably additional training. Maybe someday that becomes part of every FETP, but one way or the other, we need to develop this framework. We need to continue to work on improving program quality. So as was said this morning, if someone says, I'm a graduate of an FETP program in country X, everyone knows what that means, and it means the same thing across the world. And finally, last but by no means least, we need to find a way to assure sustainable funding for all of our programs and all of the network level elements like this conference, like accreditation, like our ability to mobilize through TEPHI Connect and other mechanisms and so forth. So those are the recommendations. I'm going to dive a little deeper in a moment, but what happened next was, actually I think it was Martin Kirk again. Martin, where are you? You're here somewhere. I probably just can't see you because of the light. There you are. I think as we went out the door of Bellagio, Martin said, you know, if we just had a couple of more days, we're really just firing on all cylinders now. If we had a couple of more days, we could talk about operationalizing these recommendations and who's going to do what. Personally, I think he just wanted to stay at Bellagio a couple of more days, but nevertheless, it was a good idea. And so thanks to our colleagues at WHO, particularly Oliver, it was really wonderful to have an opportunity where they co-hosted the meeting at Geneva with the Task Force for Global Health. So it was a WHO-based meeting, and that was one of the things that came out, and it didn't come out in our recommendations here. We're going to add it in a moment. But it also came out that, you know, we didn't just need Oliver there. We needed WHO much more involved in what we were doing. They needed to know more about us, and we needed to know more about them. Because up to this point, FETP has been kind of an independently grown, if astonishingly successful, undertaking, but not necessarily folded in as it should be to a lot of global health initiatives. So that was why we held this follow-up meeting, was to operationalize these recommendations. Here are the participants there, and again, I'm going to pause because who is at this thing is really important. I mean, however well-crafted the recommendations are, it's important for you to know these are the people who came up with it, and you'll recognize a lot of these names. Of course, a good number of them were at Bellagio. We followed up with them, and some of them are here as well. And that's great. We had continuity. But you also see new voices there. We have people from IANPHI. We have people from, and this is another way of looking at it. We'll go by agency affiliation. We had people from GORN, Dr. Tony Stewart. We had people from Africa CDC. We had people from the Joint External Evaluation Alliance, Mr. Robin Davies. And by the way, it was through that alliance they helped sponsor the meeting there, and through the Indo-Pacific Center for Health Security. We had people from the Defense Threat Reduction Agency in the US, Mr. Lance Brooks, and then a good number of people from different parts of WHO. So it was a it really amplified what we were doing. It wasn't the same group of folks meeting to talk again. It was a subset and a broader group added to them. The process went like this. As you might imagine, and I imagine it might be central in a lot of your questions right now that hopefully you're thinking about, which is I really want to hear more about the strategic leadership group, because who are they? And we met Dr. Rebecca Martin this morning and Dr. Mike Ryan, and we understand they're co-chairs, but tell me a little bit more about that. So we'll dive into this in a moment. We spent a good deal of time in Geneva thinking this through. And then for recommendations 2 through 7 that I listed before, we dive deep and tried to think about the next steps in operationalizing them. And effectively, those recommendations become the work plan, the initial work plan at least, or a draft work plan for the SLG. And then an 8th recommendation was added, as I kind of inferred it might be, or implied it might be, and that is that we need to enhance our integration with WHO and other global health processes. So that was added as an 8th recommendation. That's our roadmap, essentially. So let's dive in. Again, I'm going to spend most of the rest of my talk on this first bullet, because it's really important we get this right. Establish strategic leadership group. Its purpose is to provide a driving force for progress. Yes, we've had these problems for a while. They're not insoluble. Let's get them solved. That's the idea. Its mission is to provide action-oriented guidance and then recommendations to the FETP Enterprise, that's all of us, particularly with regard to the network level elements, because we're not going to tell every FETP program, you need to do this instead of that, although collectively we may decide to add things to our, or modernize in some ways, our curriculum. The mechanism of action is we anticipate this group will hear the voices, hear the issues from the field, bring what they know about what's going on in the field to the SLG, propose things, and the SLG will react to them. But if we go to them and we say, we need to update the curriculum, I think what we imagine they will do is say, we agree, we want to task you to do this, and we want you to focus on these 3 particular elements. Those are our highest priorities, and we'll check back in a year. And so I think what's going to happen is they'll task a series of work groups to get work done along the lines of these recommendations you'll hear in a moment. It was agreed at Geneva that TEPHINET would be the secretariat to the SLG, and so we would probably manage those work groups or coordinate them on behalf of the SLG and make sure that we were a conduit for the voices from the field to the SLG. The roles of the SLG, I'll just list them. I won't read them all the way through. If you've picked up that product I waved around this morning at the registration desk, the document, it goes through all of these in detail. But these are the things we see the Strategic Leadership Group doing. They facilitate the development and promotion of evidence-based norms, that is to say, what it is we ought to be doing and at what level. They'll advocate for support. And this is why it's really important, by the way, that we're not just renaming a group, we're actually elevating the level at which FETP is connected. I mean, think about our co-chairs. It's the leader of the Center for Global Health at CDC, the most senior global health person at the US Centers for Disease Control, and Dr. Mike Ryan, who's in charge of the Health Emergencies Program and reports directly to Dr. Tedros at WHO. These are 2 of the most senior leaders in global health in the world, and they're now co-chairing our leadership group. It's a real commitment, and they've got connections and relationships and voices they can reach out to throughout the world that we believe can help us advocate for the support that we need for FETP. And then they can do the other coordinating capacity building, promote sustainable country capacity, and so forth. The last one is very important too, by the way, which is not only to improve what we're doing, perhaps by modernizing our curricula, but expand our view as well by including some of the things you see there, appropriately incorporating the One Health paradigm into our thinking. bioinformatics, data science, non-communicable diseases as a challenge, climate change, humanitarian issues, and so forth. So we can't do everything, but we expect the SLG to say, if you can't do everything, these are the 2 things we really want you to work on this year. Over the next 5 years, let's build out a little bit there, and then let's see where we are. Now, what we came up with was at Geneva, was that the 2 co-chairs should be a senior leader at CDC and a senior leader at WHO. We had not named them at that point. When it came to membership and structure, which was asked about today and this morning, like who's on the SLG, we actually decided at the meeting that it really wasn't up for us to say which people or organizations should be on it, but rather give that lead to the co-chairs to design, and Dr. Martin referred to that this morning, but also make sure that we guide Dr. Martin and Dr. Ryan in terms of who we think should be on it in terms of their expertise, their training, their background, their experiences, their relationships, and so forth, so that we have the right voices there that make sense to us. And so that's what my next slide is. This is what we came up with. And this, again, this comes out of some brainstorming that we did at Geneva. We wanted people on the SLG to have this set of desirable competencies, experiences, and so forth. And this and a few others. And again, it's in the document that hopefully you've picked up. This guidance, of course, will lead them to have people on the SLG, probably many of the people that will be in this room right now who will be on the SLG. That's what we anticipate. But it will also probably be people that we haven't got in the room right now. There might be people with expertise in climate change, or people from FAO. I think we do have FAO in the room, but people from organizations that aren't currently perhaps having the leadership role they ought to have when it comes to guiding the FETP process. So it'll be sort of our leadership that we've had up to this point, plus. That's how we're envisioning this, and we laid out those competencies for Drs. Martin and Ryan to think about. Again, to go back and close this recommendation 1 with the key concept, the idea of this leadership group is that they will drive progress on the things that we need done. And those are the recommendations I'm going to touch on very briefly now, and then I'll stop. Recommendation 2, if SLG is number 1, was we need to develop applied EPI workforce targets. That's really a good place to start. It informs a lot of other things, including the idea of bringing in new resources. If you've got a really good evidence-based sense of how many people you need at the 2-year, 1-year, and frontline basic levels, it's easier to make an argument with your ministry and your government that we need funding to support that much training, and this is how fast we can get there. So we thought we should develop or commission some kind of a tool and some technical support to help countries develop this kind of an evidence-based framework for how many they need, how many workers at every level. And we think that'll be really important for a variety of reasons. The work group should also work closely with WHO health workforce partners, and we met with some of those health workforce people at WHO, and they can help integrate our work into the other global health workforce development efforts, which again will help us with the career path, as well potentially helping us with resources. And they can help us address those systematic issues or systemic issues. For example, just getting a workforce classification for epidemiologists so that ministries can in fact hire someone with that title and wouldn't be able to otherwise. So some of this is simple and some of this is more long-term. Recommendation 3 had to do with this rapid response idea, mobilizing and working with not only within your own country, but as part of an international response. So the SLG should identify these core competencies and then develop mechanisms, and including funding mechanisms, to support this kind of deployment. Notice that, however, that we're not the only game in town, nor have we been the first out of the gate thinking of how to do this. The Africa Volunteer Health Corps, the Strategic Health Operations Centers in AFRO and EMRO, and then AFINET's got the Africa Corps of Disease Detectives. These people have already, these organizations and platforms have already figured out ways to do deployment. We can learn from them, and whatever else we do should integrate with them and strengthen them, and hopefully have a coherent mechanism forward. Part of this recommendation 3 also is to identify incentives so that fellows have a reason and are encouraged to do such international response. And we also thought we should do a landscape analysis to find out how this is already happening, because as I indicated, it is happening. We'd love to know what's been learned already and how do we improve it and how do we support it. The final one was to assure something called duty of care. It's a term of art, but what it means is if you send an epidemiologist off to somewhere like the DR Congo, it can be a pretty traumatizing experience and certainly very stressful. We want to make sure people are treated decently when they get back and not forget about that or just assume that it's going to happen. Recommendation 4 of our 8 assure sustainable funding. Easy to say, harder to do. But we thought a great way to start is to figure out how to develop a business case so that when we go to a minister or a foundation or WHO or wherever we go and say we need more support for this, they're hearing that from every program in the world. Every program wants more support. But if we could say, here's why. For every $100 you invest in FETP, you save $5,000 in costs avoided by when you let an epidemic get out of control or something along those lines. But that has to be evidence-based, and we need to commission that work and really take the time to develop the evidence for the value that this program brings to countries. And it's not all just value in dollars, but it should be in dollars as well. We also thought it would be great to commission a sort of state of play. What's already happening? How much work is really being done? Each of you probably knows about your corner of the universe, but it's very hard for us to put this all together and have the information we need to really describe how many people are being trained, at what level, in which countries, for how long, and so forth. So it'd be great to actually put that information together. And I think the SLG could use that to try to look for more resources. Recommendation 5 has to do with, again, modernizing the FETP Enterprise, the programs themselves in terms of curricula, and also our enterprise level things like this conference, like accreditation, and so forth. So the SLG should continue to monitor the need for change and encourage the changes. The second one there I mentioned is, it's come up several times, and you heard Dr. Oliver Morgan refer to this morning when he talked about soft skills, that it's been noticed by some people that we have very well-trained epidemiologists who aren't that particularly good at dealing with people in crisis situations, that they need to learn how to show empathy and how to pause and how to explain what they're doing in a way that makes sense to the people that they're trying to get information from. Now, many people do this very well, and many people instinctively do it very well. But an FETP program, the sense was everyone should be given the tools to do this well. The third one's important too, and this came up this morning, that part of this is to recognize that an FETP program, whether it's a 2-year program or 1-year program or frontline, it doesn't end when that person graduates. That epidemiologist will have experiences and new needs to learn and new needs to refresh what they know, and they'll find themselves in new positions where they need to know new things. We need to provide, as an enterprise, the opportunities for lifelong learning, and TEPHINET's working on that now with their learning strategy. Number 6 of 8, accelerate institutionalization. Again, much easier said than done, but this, as Kip indicated, this has always been the goal, that we need to find ways so that when an FETP program starts in a particular country with the support that it needs to get started, that there's a clear plan for weaning that country to the point where it is self-sustaining. Weaning is not the right word. We're helping to build towards self-sustaining programs. And many countries have done this, by the way, and I should be really clear about that. We should be very proud of that. Countries around the world have found ways to do this. It's a big challenge. But we want to be more planful about this. We want the SLG to find a way to make this happen faster, to provide the tools, the support, the technical assistance, and the advocacy to help make this happen. Number 7, assure and improve quality. We all know that this is important. We've done a good job, I think, collectively designing and then collectively running an accreditation system for the 2-year programs. We may want to move to such a system for 1-year programs. That's for the SLG to debate and think about and for you all to weigh in on. And there may be other ways. There certainly are other ways to improve quality in each program. And there may be programs that have found ways to do this that we could learn from others and incorporate those best practices. So accreditation is not the only thing, but everyone felt that in particular we should find a way to expand and find the resource to accelerate the rate at which accreditation happens. And then finally, recommendation 8 that was added in Geneva, we need to better integrate this FETP enterprise with all these various global health initiatives and priorities. And as an initial step, many people said, you know, we're already doing that, or we're already working with that program, and we're just not getting credit, or this FETP is working in that space with WHO. So we thought maybe it would be good to commission a paper that maps out how we're already doing this. And again, this is all part of the technique of building support for what we do and potentially increasing resources. But also to map out the ways that perhaps we should be doing it and aren't doing enough of it. So that was one specific suggestion to come out of this. And the other, of course, was that the Strategic Leadership Group should advocate for appropriate inclusion of field epi capacity in these global programs and initiatives. You know, when you talk about universal health coverage, again, people, this came up, I think Seymour said this in the microphone, people often think immediately of health care. But even if you focus on healthcare, you still need to know how many hospitals you have and where your populations are and who's getting sick from what, so you can decide where to put clinics and where to deploy nurses, so forth. Those are epi questions. So there's a lot that field epi training programs can do to support the efforts toward that one particular global health initiative, and there's many others where we can help as well. When we left Geneva, these were our immediate next steps. We were going to ask WHO and CDC to name the co-chairs. We wanted to share this work at the 10th annual or biennial TEPHINET Global Scientific Conference, and then define and carry out the process to determine the membership of the SLG, and then get this thing going. Develop a change management strategy and a process to start addressing all these particular challenges that are reflected in the recommendations. Now, we can put a check mark next to the first one. We have our very senior, and as you heard, very dedicated and committed, and by the way, very well informed and experienced co-chairs, Doctors Rebecca Martin and Mike Ryan at CDC and WHO respectively. This is where we are today. So thank you for your patience in going through all this, but this is your opportunity to tell us what you think of the work that all of those leaders did in coming up with this set of recommendations and this set of priorities for the work that takes us forward. So thank you for your attention, and now let me turn it back over to Dr. Reddy.
Thank you. Thank you, Patrick. Okay. So, perhaps the best way to think about the field, the global FETP enterprise, is the analogy or the metaphor of a ship. You build the ship as you're sailing it, okay? So I just have a few slides on the way forward. May I have my slide set, please? And then I'll call upon our last two panelists and invite the entire panel on stage, and we'll be able to answer the questions that you putting into the app. We're very excited about the app. It's the first time that we're using the app, so we really look forward to your participation, your input of questions, and the panel will do its best to answer your questions. Okay, so what is the way forward? So bear in mind, this is more or less a recap of what has been said from the morning. So remember that the Strategic Leadership Group was the first recommendation from the Bellagio meeting, that subsequent recommendations for action comprise a draft work plan for the SLG, and that this SLG is tasked with driving continued progress toward global applied epi capacity via the FETP Enterprise. Okay? The mission, once again, is to provide a high-level commitment and driving force for progress towards global applied epi capacity through action-orientated guidance and recommendations to the FETP Enterprise. Okay? So this SLG will prioritize and commission specific work as appropriate. It will advocate for support for all aspects of the FETP Enterprise, be this for country-level program support or for the network-level elements, example, program accreditation, learning resource development, network communications and mobilization, and global and regional scientific conferences. And these network level elements actually coincide with the key work areas of TEPHINET, of the global network. Okay, in terms of support to the Strategic Leadership Group, the TEPHINET will serve as the secretariat for the SLG. There will be tasks and work groups commissioned by the SLG will be overseen by TEPHINET. TEPHINET will be responsible for communicating critical issues and challenges facing the FETP enterprise to the SLG. So in a sense, the TEPHINET Secretariat will serve as the conduit between the SLG and the FETP enterprise. TEPHINET will also ensure that the SLG's guidance and recommendations are put into effect. The proposed membership, as you've heard already from this morning and from Dr. Patrick O'Carroll, is currently Rebecca Martin and Mike Ryan. okay? The model of membership, the members themselves, their duration of term, the selection process, and the roles and responsibilities of the membership of the SLG is still to be determined. And this is the reason why this is part of the theme of this year's conference. While we are presenting it to participants to get their inputs, it will be presented to the program directors meeting on Saturday, as well as to the advisory board on Sunday. And the intention is to get all the inputs that we can get in order to move the process forward. That's my last slide. Okay. Okay. I'd like to introduce the last two members of the panel before all members of the panel come up and sit on stage. So Dr. Natalie Mayet is the Deputy Director of the National Institute for Communicable Disease and is currently serving as the Chairperson of the International Association of National Public Health Institutes. Dr. Mayet qualified as a medical doctor from the University of Natal in 1983 and obtained further qualifications in tropical medicine and hygiene, public health, health services management, and occupational health. She has been involved in public health for 35 years and is completing an MPhil on strategy at the Gordon Institute of Business Science. Dr. Mayet is currently responsible for the South African Field Epi Training Program oversight within the National Institute for Communicable Disease and is facilitating the entrenchment of field epidemiology as a discipline within the Ministry of Health of South Africa. She is a member of the Africa CDC task force that has prepared the framework for workforce development for member states. Okay, may I please ask Dr. Patrick O'Carroll, Dr. Kip Baggett, and Dr. Natalie Mayet to have a seat on stage. And it's with great pleasure that I introduce our last panelist. It's last but not least. Okay, it's a great, he's a great friend of the FETP world. Dr. Babatunde Olowokure is Chief Health Emergency Information and Risk Management Department of the World Health Organization Emergencies Program. Prior to this appointment, Dr. Olowokure worked in the WHO Western Pacific Regional Office, where he led a team focused on early detection, assessment, and response to acute public health events. He also played a key role in managing the Western Pacific Regional FETP Fellowship Program. From 2013 to 2015, Dr. Olowokure served as the first Director of Surveillance, Disease Prevention and Control of the Caribbean Public Health Agency, where he was instrumental in the development and implementation of the Caribbean Regional Field Epidemiology and Laboratory Training Program, or CRFELTP. Dr. Olowokure earned his medical degree from the University of Maiduguri and completed his PhD at the University of Warwick. He is a fellow of the UK Faculty of Public Health and advocated for the founding of the UK FETP program. Dr. Olowokure, welcome. Please join the panel on stage. Okay. I'd also like to invite my colleague Tina Rezvani on stage. Tina will be assisting us review the questions that you put into your app. So whilst we just... someone has the hand mic, I think I saw it. No problem. Okay. So, whilst we're just filtering through the questions and, trying to get them in a certain degree of order, I'm just going to ask Dr. Natalie Mayet and Dr. Babatunde Olowokure to just give us some comments on their experience of the roadmap development. They were involved in it at various points in time. So maybe just to chat informally, imagine you're on the breakfast show and you're just chatting through the process while I just liaise with Tina to look at the questions. So please, if you'd just like to chat to the audience, I need to give you a microphone. So may I, you don't need yours, you've got yours on. Okay, thank you. Please Mayet, would you like to start?
Thanks, Carl. The word enterprise conjures up this. I'm getting a lot of feedback, Carl. Is there? Could I use another? It's okay. Yeah. All right. So the word enterprise conjures up this notion of forward-thinking, futuristic thinking, new alliances, strategic alliances. And certainly that's, I think, the point where we are at the moment in terms of formulating new strategic alliances. And way back when music referred to institutionalization of our FETP programs, the ideal home for this now, this program is in National Public Health Institutes as new strategic alliances. National Health Public Health Institutes are responsible for surveillance, they're responsible for operational research, they're responsible for outbreak response, detection and response, they're responsible for teaching and training, and they're responsible for communication. That will inform policy, that's scientific publications. These are all the core learning outputs of a FELTP program. So we require FETP programs to be embedded and institutionalized in National Public Health Institutes. IANPHI as a network, Africa CDC, and WHO are on a drive to strengthen health systems capacity within countries through public health institutes. So this is the ideal home because this is where you have political will to establish and to strengthen public health institutes. And so comes the funding where you have political will and the sustainability to ensure that these programs are entrenched. So we need FETPs in public health institutes to lead public health institutes, to provide service within these public health institutes, to mentor our future cadre of epidemiologists, and to drive policy implementation through public health institutes. So in this process of this enterprise advancement, we ask ourselves, who's the Captain Kirk in all of this? Who's the Dr. Spocks? And that's all of us in this room. We need to drive it so that we ensure the sustainability, the institutionalization that music referred to way back in 1990, and that we ensure that we are the ones responsible to mentor and to guide our FTP programs for sustainability. Thanks, Carl.
Okay. So, I'll follow you.
Thank you very much, Natalie. Dr. Olowokure, may I ask you for your comments, please?
Thanks very much, Carl, and thank you, Natalie, for mentioning Spock and Kirk, because I think that was the unspoken thing in the room. Because, yes, I think it's futuristic, but I think, as Kip has said, I mean, it's really back to the future, because many of the issues, the recommendations, these are problems that I personally have wrestled with in the various programs that I've dealt with over the years. And it's really, I think, really refreshing now to see they have a home. There's a roadmap which we as a group can really start to look at and move forward in dealing with the various issues. It's something that I think we can get a lot of buy-in, because we are now much more structured, much more organized. We have a secretariat behind us, which is TEPHINET, and with the leadership of whoever is going to pilot and steer the ship, I think we are really heading out, not into quite the unknown, but at least, and not going where no man has gone before, but at least we are heading towards a destination that we can actually see somewhere in the distance, rather than wandering around like a lost tribe in the desert. Over to you, Carl.
Thank you. Okay. So my colleague Tina, who's actually the communications manager at TEPHINET, is going to assist us by reading out the question, and then we'll ask one of the members of the panel to attempt to answer it or shed more light on it.
Great. So thank you for your questions. We have several really wonderful questions that came in. I doubt if we'll have enough time to get through all of these, so we will save all of these questions, and I will email them to the panel later, and you guys can decide, how you want to address them. But we'll get through as many as we can. So the first question is, leadership and management is the foundation for enabling effective management of health emergency programs. How much emphasis is given to this in the global FETP enterprise?
Yep, sure, I can. Mike, please. Great question, and I think I don't remember the numbered recommendations off the top of my head, but there's definitely a recommendation that speaks to the need for innovation, reviewing where we are, reviewing the curriculum, making sure that we are addressing the key competencies that are necessary for the FETP that we think is needed for today and for the future. And I think leadership and management is absolutely one of that set of those competencies. This is not a new discussion. In some ways, this is, similar to some of the other things, revisiting where we've been before, because there are curricular materials for leadership and management for FETP. There are many programs out there that use them, but I think we can do a better job. We recognize the importance of it, and I think aligning with what Natalie said, with FETPs being a part of National Public Health Institutes, a key part of that success is being assured that FETP graduates are positioned not only to be strong field epidemiologists, but to be leaders and leaders of institutions. And so, absolutely.
Thank you, Kip.
With the challenges currently faced by some countries in taking up funding support and ownership of FETP, what is the stance of US CDC commitment to funding FETP in the near or long term?
Why the laughter? Wait, is that one for me? I should start by saying that the CDC is absolutely committed to FETP. I mean, you saw today Dr. Rebecca Martin on the stage making her commitment to the strategic leadership group and demonstrating the importance that she believes FETP brings. Most of you have been in the room with leaders of CDC who have talked about the importance of FETP. Dr. Frieden consistently referred to FETP as the most important global health program that we do at CDC. So the commitment is absolutely there. Of course, I can't commit to funding. Our funding comes in one-year cycles for the most part, and so it is difficult to commit to funding. But we are committed to FETP, and we are committed to participating in the process of ensuring there is sustainable funding, whether CDC, whether other parts of the U.S. government, which are important contributors like DITRA, or whether it comes from other sources. We are always engaged with this large network of partners that care so much about FETP.
Thank you, Kip.
It says, great presentation, successful on the top down. How are you all planning to approach the bottom to top, or grassroots, which is essentially the core of field epidemiology?
Patrick, please.
I was about to point to Carl. You pointed to me first. No, you've put your finger on exactly the challenge, I think, as we start to structure the senior leadership group. The name of that group might make it sound like these will be these ethereal leaders that we get to check in with once or twice a year, and they'll tell us what to do, that we're the us and they're the them. In fact, we have to make sure that frontline program leaders, program developers, experienced FETP people who are currently in this game are very well represented on that group. We have to make sure that some of our key, strong regional implementing partners like AFINET and EMPHINET and SafetyNet are included on that group. So it may look like top-down when you say strategic leadership group, but it's sort of servant leadership. It's us figuring out a way, an efficient way, for us to lead our collective enterprise. So the questions have come up a couple of times, and they're really the very next question to ask of Rebecca and Mike, which is how do we make sure that the membership of the SLG truly reflects the perspectives and the needs and the vision and the energy and the experience of FETP leaders. But beyond FETP leaders as well. And that's something I think it's important to add to it, because we're not only people in allied fields, in FETP-V, for example, and FAO, but also people who bring different perspectives to it. Maybe somebody from the Africa Development Bank, for example, who can take a different view of how to do development and bring a different kind of perspective to how we lead. So it won't only be field level people on the SLG, but absolutely it will have a lot of field level people on the SLG. So that's one thing. Secondly, we don't yet know how the existing structures, like say the annual program directors meeting, which we're going to have at the end of this week, which is a terrific annual opportunity for program directors to tell TEPHINET what their needs are, what their priorities are, and to give feedback to what TEPHINET's programs are doing and so forth. We don't know how that will relate to the SLG yet, but we know that it's a tremendous opportunity to get field level intelligence to TEPHINET, and then TEPHINET, as you heard, is the secretary to the SLG. So how those existing structures relate and how they should relate, yet to be determined. I think some of the groups, like the TEPHINET Advisory Group, if you looked at the membership of that group, I think you'd say, well, every one of those people should be on the SLG, and that's probably true. If that's true, do they also need to sit on an advisory group, or does the SLG essentially become the TEPHINET Advisory Group plus some, elevated to having very senior leaders like Dr. Martin on it as well? So those are discussions yet to happen, but I can say this, and I know those of you who have been on the stage here have been involved in this, and some people in the audience, we've been committed from the very beginning that whatever we do differently, we don't break what is magnificent about the FETP undertaking, the FETP Enterprise. And so we're going to be careful to nurture it in a way that does give voice from the bottom up, because that's the reason we're doing this work, is to serve and for us to collectively lead ourselves into the next set of competencies.
Okay, Patrick, just to take off from what you said, I think the American expression for that is, don't fix it if it ain't broken. Right. Right, okay.
You can see Carl is really picking up on the Americanisms, and he's only been here a couple of months.
The next one is not a question, but it's a very profound comment. They said, Patrick, you look really cool with that microphone.
It's so cool that he broke it.
Let's make sure we recorded that in the minutes.
Okay, what should a country program do to incorporate the roadmap and recommendations into their strategy and messaging to their country's leadership?
That's a very interesting question.
Yeah, I mean, I have a couple thoughts on that, I guess. One thing I would say is that while this is taking some time to get the strategic leadership off the ground and governance structures in place, and while that's happening, I don't think we need to sit around and wait to take action. I think there's been a lot of thought that has gone into this document, the roadmap document, the readout from those meetings. And as Patrick just pointed out, there's a lot of overlap in the groups represented in these meetings and people that are very close to programs and understand the needs on the ground. So I do think there's information in there, there's guidance in there that can be informative. I know for us at CDC, we are already thinking about how to shape our work to fit into the recommendations of the roadmap, knowing that there will be more structured process to come, but in the meantime, we want to be thinking about these things already. I think at the country level specifically, I would look at at least one recommendation is the one on institutionalization. I do think there is work that can be done there right away, and we at CDC have worked on indicators for institutionalization, something that we think and hope will facilitate the process. And so anybody that needs more information on that, we would certainly be glad to talk to you about it. Let me stop and see if others have comments.
Sure. I just wanted to ask Dr. Mayet, being so involved with overseeing the South African FETP, what are your thoughts on that particular question?
So I think the IHR regulation sets the scene for having epidemiology entrenched within countries. And I think when countries develop their joint action plans to address the need of fulfilling the gap for the for epidemiologists within country, then they frame that strategic intent together with the Ministry of Health as to what is the need in terms of the numbers and how do they advance bringing in epi capacity. Do they start at frontline? Do they start at the 2-year course? And how can they form alliances with neighboring countries that can, who have established FETPs to train up and to seed the program within countries? So it's very much dependent on where the country is at in terms of development and establishment, but work with the ministry and use the IHR framework to catalyze its development. Yeah.
Sure. And Dr. Olowokure, you've been instrumental in setting up a number of FETPs in different regions of the world. What are some of your thoughts regarding that issue?
I think I totally agree with what my colleagues have said earlier with regards to this. Some of this work is already ongoing. Some of them are still a bit of a challenge. But if we specifically look at recommendation number 8, which is the one about aligning with global agendas, I mean, in particular, if we look at the 3 billions, which is part of the WHO Global Program of Work, number 13. So when we look at that, those 3 billions are all interlinked. So one is about health emergencies, one is about UHC, which we heard a lot about this morning, and the other one is about promoting health. And FETPs, in terms of the epidemiological capacity they provide, are key and critical for all 3. And so those things are all, I mean, WHO is already implementing those in the countries. We're already operationalizing our planning for next year, and we do 2-year cycles. And I can speak particularly from headquarters. We've already put FETP into our planning cycle for the work that we're going to do both with our regions and our country offices. And so from our perspective, this is a no-brainer. We will work together with the country offices and the ministries of health, as well as FAO and OIE, because we can't forget FETP-V as well. And so we will be providing support in order to implement particularly that part of the recommendations, but again, working across all the recommendations that have been proposed.
Thank you.
Actually, could I add one thing? I would really like to take that question as a suggestion, which I think sometimes a question is really a really good idea, which is that again, this is an us kind of conversation, so we, each of us, can look at these recommendations and think, can we use these in our own strategic planning? Because as you saw, with the great level of expertise that was reflected in these 2 meetings, a lot of very clever people, many of them in this room, helped to write this, helped to develop these, and break these into specific recommendations. And I know for just one example, I casually, in a conversation when I was in London, discovered that I think it was a colleague in Jordan said they're just using this as their blueprint for strategic planning for their own FETP. They were very excited about it. So I think these are ideas that have been banged around and talked about for years, as we've indicated. There's no reason in the world for anybody to wait in terms of how it might influence your own planning with your own FETP.
Great. Thank you, Patrick.
Until the time that when we can meet required numbers, some kind of prioritization within countries and regions might be required to utilize the FETP workforce. Has the SLG considered, or do they plan to consider this?
Could you say that one again?
Sure. So until we can meet the required numbers, is that the 1 per 200,000? Some kind of prioritization within countries and regions might be required to utilize the FETP workforce. Has the SLG considered, or do they plan to consider this?
I mean, whilst you're thinking, just to point out that, the SLG is still in the process of being constituted. And
so we can say they haven't considered it yet, for sure.
Not yet, but we can certainly propose it to them. So, once they are constituted.
I'm not sure I fully understand the question, but I'll take a stab. The premise is that until a country reaches the target, which I'm assuming is the 1 per 200,000 target, how do they prioritize? I guess, how do they prioritize kind of getting to that target or prioritize their resources for field epi training. And I think I think this gets to something that Natalie said, and I guess there are other important initiatives out there, one of which is IHR and IHR commitments and joint external evaluation. I venture to say that most of the countries represented here have undergone a joint external evaluation and have or are working on a national action plan. And I think that process is really meant to help to guide the prioritization of your activities related to workforce and other areas that are important for IHR. So I would sort of complement your thinking about FETP with the priorities identified in national action planning. I think also with national, for those countries that are in the process of developing or strengthening their national public health institutes, often that process involves a prioritization process, sometimes through the strategic development tool or things like that, and putting these things together. Don't think about FETP in isolation of these other important initiatives.
One of the issues that came to my mind was that in terms of the prioritization, in terms of the pyramidal model for training, one of the most efficient ways of rapidly building capacity is to start off with frontline training, and then as a first priority. And then as people are trained in the front line, they can use that as a screening tool to select people for the intermediate and finally for the 2-year training. Because I guess Rome wasn't built in a day, and we're not going to build this capacity or reach the required number target within a year or two. It's a phased process, obviously. So I just had the thought that it would be reasonable to start with the front line for countries which don't have front line, for example. I don't know.
I think one of the things also, many countries have workforce strategy documents, workforce planning documents, and many of them don't actually include field epidemiology as a cadre within those workforce plans. And I think this is where we could influence for that FETP becomes a cadre within those workforce plans. And it's aligned again with your IHR. But I think it needs to go into the strategic planning document at the Ministry of Health for workforce development.
I mean, clearly the role of the WHO in that.
Absolutely. And absolutely. And I think it's really, really important, again, as has been mentioned in relation to the IHR, whether countries are able to get one per 200,000 is another issue. Whether they need 1 per 200,000 is also another issue. And I found it quite instructive that in the vision of the SO, no number was mentioned. It's what is relevant for that country. And I think that's really, really important. And when we talk about the joint external evaluations, there's a section there around health workforce. And there is also another section around surveillance and various other capacities that are required under the IHR. And it's really important, again, as has been said, that when countries are post-JEE and they have their plans, that they really, really, really do look at workforce as a priority. In several of the JEEs that I have participated in, there has been this lack of field epidemiology capacity, and actually prioritizing that and institutionalizing it, because that is then what happens with the prioritization. If you prioritize that, then it has to be institutionalized and it has to be funded, and therefore these are part of the recommendations that we, as the SALG, will also drive forward. Thanks, Carl.
In fact, it's exactly 3 o'clock, and I know it's the afternoon break. Shall we take one more? Shall we take one
also,
more?
If anybody wants to make are these mics live in the audience? They could make a live comment.
We can, yes.
So if anybody wants, while you're maybe reading one more, if somebody wants to make a comment at the mic, we didn't mean to shut down your conversation. We want to make sure everybody's voice was heard, but if there are people who want to come to the mics, feel free to do so.
Yeah, and as I mentioned, we have a very long list of great questions, and I can email you guys these questions too. Okay, so the last question from the app. So this person said, with appreciation for and no disrespect to the experienced and knowledgeable contributors so far, how will new voices from an evolving world of FETP be included? These young voices must also help shape the future of FETP globally.
It is a great question, well worded. Yeah, go ahead, Carl.
Okay, I mean, just a quick comment. I think that's a very relevant question. And I mean, just in terms of the experience, what we found over the last few years, and Natalie will attest to that on the South African FETP, is that more and more the residents came forward and were telling us what they wanted. You know, and I think that is critical because we are developing field epidemiologists and they need to be empowered and engaged and actually take their future into their hands as well. And as a result of the residents coming forward and asking for things, we instituted a lot of changes to the program in terms of the content, in terms of what they were learning. We've given them in the essay FETP a Dale Carnegie course on public speaking, self-confidence, self-awareness. We felt that was necessary. They needed a lot of support with scientific writing because in the South African context, many residents use English as a second or a third language. So we were able to get a support of a scientific writing advisor. They wanted, in addition to Stata and EpiInfo, they wanted R, right, the new statistical package. So we got them an orientation and training in R. So yes, I think it's critical that residents in training actually put forward their needs and articulate those as best they can.
And I think, again, going to the idea that questions are often great suggestions, maybe we should consider making sure there's at least one person on the SLG that's a recent graduate from an FETP program, so they could bring a more recent point of view to the training discussions.
Yeah, I think it's a good idea. I mean, I think we've heard this twice now, and maybe there's even more comments in there to this effect, so we'll take that to heart. I think right now our avenues to the programs themselves and our close connection to the graduates are the program directors and the TEPHINET advisory group, which they represent the members. And so that's one avenue, but probably not sufficient for what we're talking about. So I think we can build on that. And then also it was mentioned in the slides, the change management process that has not been fleshed out yet, but I think this is a signal that process certainly needs to include a mechanism to continually solicit feedback and input from recent graduates, from programs, from the field.
Okay, so I don't see anybody at the microphones, but what I'd like to propose is thank you. Please.
Thank you. Hi, I'm Matt Moore. I'm the director of the Global Health Security Program at CDC Vietnam. And I just have a follow-up question for Dr. Babatunde about the recommendation number 8. And it specifically has to do with the annual IHR self-assessment. I think, as you know, there's not actually an indicator there around workforce. But if there were, it would be very, very helpful in keeping the conversation going every year, year after year, instead of every 5 years, about workforce development within the context of IHR. So I just wonder whether there's any possibility or if there are discussions about harmonizing the annual self-assessment with the JEE in a way that would incorporate workforce development.
Thanks very much for your question. I think this has been something that we've been wrestling with in terms of aligning the SPA, which is the self-reporting tool, which is done on an annual basis, along with the 5-year JEE as well. And human workforce, as you rightly say, is not in the SPA. I can take your views back to the team that actually deals with that, and we can provide you with an answer, I hope, at some stage. But the SPA itself has just recently been modified, as I'm sure you're aware. And so change may not be very soon in coming, but I will give them the views that I've heard. And you're not the first person who has said this as well. And so I'm hoping that we will have some way of trying to align the two tools together. Thank you very much for your question.
Thank you. May we take the last, there's two, okay, the last two questions. I'm not sure who was first. Okay, please, go ahead.
Thank you. I come from Makerere University School of Public Health. And I wanted to ask a question about the roles of schools of public health in the FETP Enterprise. we've been training epidemiologists for some time, and for example, in the Ebola crisis, they were able to form part of the workforce that was effective in handling that. But in this discussion, the role of schools of public health seems a very silent part of the whole discussion. And yet, this is a workforce that already exists. When you think about the resource constraints that some developing countries have and their ability to initiate and to fund a new program, it may not be very easy for some of them. So I just wanted to find out what your opinion is about the contribution of schools of public health to this.
May I ask Dr. Mayet as a IANPHI representative?
Thanks. That's a very, very important question. And certainly there's an International Association of Public Health that WHO is working with, together with IANPHI, as to how we can bring them all together. I think it's still early stages of discussion, but there's recognition and appreciation that there are epidemiologists within countries that are not necessary field epidemiologists. And how do you build collective epidemiology capacity in the country by different streams, not necessarily only field epidemiology? And I think this is where WHO also have, I think, modified the field epidemiology to take out the field component, but to 1 per 200,000 epidemiologists. So I think it's an important question, but work in progress. Let's watch this space.
Patrick?
Yeah, let me just reflect, because it came up at an earlier question too, that I think one of the things I liked about what the groups came up with was it wasn't a focus on the schools per se or on FETP programs per se, but rather on field epi capacity. And I think if we stay true to that vision, there might be a number of paths to field epi capacity. But as Dr. Morgan noted this morning, there is something special, and I have an MPH, but I can tell you that I didn't know nearly what I needed to know, what I was taught in EIS, our FETP program. Working in the field, how to work in the field is not something that many schools of public health have an opportunity to teach, because their students don't typically get deployed by the public health authority during their training. And that's kind of one of the unique aspects of FETP. So in the spirit of not breaking or not trying to fix what's not broken, it was some of the earliest conversations at Bellagio where this philosophy of learn by doing and providing service during the training to the government ministry or to the National Public Health Institute and so forth is part of the beauty of an FETP program. But there may be a number of ways for people with training in public health and training in epidemiology to gain that experience, and it may sometimes not be through an FETP program. It may be through real-world experience as an employee of a ministry, for example. So I think if we keep our eyes on the capacity and not worry so much about exactly how it gets done, it may be that there's a number of ways to build that capacity. I still think FETP will be a primary way, but there may be countries that take special routes to that are perfectly legitimate.
Sure. Thank you, Patrick. The last question is from Dr. Carmen Sanchez.
Thank you. I'm Carmen Sanchez Vargas, CDC retiree, and currently an independent consultant in capacity development in public health. Well, I wanted to congratulate all of you who participated a year ago, almost a year ago, in the group that developed these recommendations. They are extraordinary, and they reflect the work that CDC been doing supporting TEPHINET and the collaboration with main partners like WHO and others who have supported this initiative of TEPHINET along the years. So I couldn't find anything that I wouldn't love or not support. So congratulations, this is really extraordinary. And my expectation would be that the program directors meeting and the advisory board endorse your recommendations, fully endorse the recommendations. Now I have a question, and I would like to hear your reactions to this. With a little preamble. Last night, from the jail where I am currently working, as a consultant for juvenile detention facilities here in Georgia, I listened to the presentation of Dr. Jeff Copeland, when he mentioned that in the 80s, in a collaboration with WHO, he proposed strengthen workforce capacity at WHO and countries levels by setting up field epidemiology training. And well, probably it wasn't the time. He didn't went into explaining what happened, but the proposal that he and others developed was refused at that point in time, and he congratulated the audience and everybody for having achieved what is being achieved to this point, tremendous success of field epidemiology training programs and TEPHINET. Anyways, so talking about things that take 20 years to develop and that probably don't get supported at the beginning, maybe they are too early in the making. There was this initiative of TEPHINET at the very beginning of its establishment, supported by CDC, to develop, to create an outlet that does not exist, but that at that point in time was seen as very necessary for field epidemiologists globally. And I was thinking last night when I listened to Jeff Copeland, well, there is still need for this outlet. And thinking of the global, the recommendations for the Global FETP Enterprise, I thought, well, this is still very cross-cutting. And that was the creation of the International Journal of Field Epidemiology that has a zero issue that was distributed in the first global conference in Canada. There were, many discussions about the cost, making it paper, not paper, and many, many things that had to do with engaging in satisfying this outlet that does not exist, this need that hasn't been satisfied for having a tool for training. And I was once talking to Dr. Copeland about how much this idea was similar to that of the National Center for Chronic Disease Prevention and Health Promotion, that created a very modest outlet to increase the capacity of local health departments in chronic disease prevention, health promotion. And it's a very modest journal still, it's only online, but it has contributed dramatically to increase the capacity of local health departments to do chronic disease prevention, control, and health promotion. Anyways, my question to you is, have you considered something going back 20 years, like supporting the creation of the International Journal of Applied Epidemiology as a tool that would go across the different recommendations, supporting the different recommendations that you have? And I think, well, strengthening partnerships, training of residents and graduates, and dissemination of achievements, but mostly it goes to increasing the quality of the programs and creating avenues for disseminating the high quality work that they do.
Okay.
So what would be your reaction? Thank you.
Sure. So would anyone in the panel like to attempt an answer on what would be the role of a publication in order to disseminate the results and the findings and the... Natalie.
So I do think that the leadership team needs to formulate a communication strategy. And the communication strategy needs to be bi-directional. How do you solicit input? And what kind of tools you would use to disseminate information. And that needs to be collectively formulated. What's the best way of getting messages out quickly? And what's the best way of getting scientific publications out to existing journals or new journals? And I think that communication strategy needs to be formulated as part of this exercise.
Perfect. Thank you so much. Ladies and gentlemen, thank you very much for being present this afternoon. I think this was a very interesting session, and I'd like to really thank Dr. Babatunde Olowokure for being here this afternoon and participating, Dr. Natalie Mayet, Dr. Kip Baggett, Dr. Patrick O'Carroll, and of course, Tina Rezvani, our communications manager. Thank you very much. Please feel free to follow up over tea with some of the panelists. And of course, this is an ongoing conversation. Tina will email out the questions and the responses to them. Thank you very much. Thank you.